It just turned 7:35, so I'm going to do a share screen. Sorry that I had my video off. I wasn't even paying attention to that. Do a share screen and get started. Again, I really appreciate that you joined and your interest. All right. Bridging medicine and fitness, an optimal approach to patient referrals. The first thing I wanted to do was to make sure that everybody is very clear on what this webinar is about so we're on the same page. This webinar is specifically set up to help streamline the referral process to fitness professionals to build the bridge between medicine, rehab, and fitness. I'm about 30 years in my career. I've done a ton of presenting over my career, especially the last 20 years. And it's become very clear to me that when you have an audience in front of you, there's always a learning curve and a wide range of experience. And so because of that, um, if anyone who is attending this has little to no understanding of exercise principles or programming, this webinar is still going to be of benefit. But on our website, the mfrinstitute.org, I would highly suggest we have um, a bunch of educational videos that can really help understand. And I would highly suggest that you check them out and do a deeper dive into these topics. So there is an assumption that most attendees have a general understanding of exercise principles and guidelines. And the reason why I bring that up is because this relates to your conversations in your clinic with your patients. And the less you know about exercise programming or prescription, the less you know about the guidelines, the more challenging it would be to have discussions um, with your patients. So it's obviously, and this is also a reason why there's a gap between medicine, rehab, and fitness. We don't speak each other's languages, generally speaking. So it's obviously a very important thing to consider. But with that said, again, if you don't understand programming or prescription a whole lot or the guidelines, that's okay. You'll still benefit from this webinar. And there's also an assumption that attendees have at least a general understanding of the trans-theoretical model of behavioral change and how to structure questions and conversations based on the stage that the patient is in. We're going to talk about this a little bit, but again, this is a webinar. It's kind of like an intro webinar designed to give kind of start with a high level view, and then I definitely plan on doing more, like part two, part three, part four. We can all decide how many parts there will be to just start to do deeper dives into some of these topics. So there will be some helpful examples provided in this webinar, but the Medicine Rehab Fitness Institute webinars, which are going to be ongoing now. We just started these actually on, what's today, Wednesday, on Monday, and there's going to be an ongoing series. So for those of you who aren't familiar, I co-own a company called the Medicine Rehab Fitness Institute at mrfinstitute.org. One of the co-owners, physician assistant Sheila Aubois, is on this webinar right now. Elise Freeman, who you see up there, she is an exercise physiologist that helps do virtual training, which I'll talk about a little bit. And then we also have a physical therapist, Dr. Thomas Hammond, who co-owns it as well. And all of us have a huge passion for building this bridge, which is why we created the company. And we also have a soft partnership with the with the Medical Fitness Association that will likely grow into a deeper partnership. But so we have started webinar series, a podcast series, and now this webinar will be an ongoing series. Real quick background, I'm going to make this brief. About 30 years in my career, I've been staff at Duke, UCLA, Beth Israel, and Mount Sinai Medical Centers. I'm in New York City. And I've also been staff at several private practice facilities. Um, and I've spent the last 20 years working alongside orthopedists, physiatrists, physical therapists, chiropractors, podiatrists. I actually teach an intro to um, sports medicine and rehab course for an exercise science program here in New York City. I teach strength and conditioning. I teach a weight training activity class, and I teach nutrition and health. And I also, with the American College of Lifestyle Medicine, I was the founding chair of their fitness and medicine member interest group. And That was from 2017 to 2020. And just prior to the pandemic, I teamed up with Jeff Duran, who is the chair of the board of directors for the Medical Fitness Association, and he oversees some of the most um, successful medical fitness facilities in the United States. And we teamed up and we're having regular meetings because we wanted to create a patient referral subcommittee. A lot of the stuff that we were talking about back then is what I'm going to be talking about tonight. And hopefully you can already tell I have a big passion for this. But unfortunately, the pandemic happened and things fizzled out, and then my term of chair wrapped up. But very passionate about this topic. Another thing is you hopefully saw when you responded to this and I said I'm a doctoral student and doing some what's called action research. So I have a bachelor's in kinesiology, a master's in exercise and sports science, and I'm currently about halfway through a doctoral program in kinesiology. I'm pursuing an EDD, not a PhD. And I actually, up until the course I'm in right now, which is called Action Research in Kinesiology, I actually was of the mistaken view that even though I'm going the EDD route, that my dissertation was going to be on traditional research. So, control group, couple intervention groups, etc. And I have now learned just literally weeks ago that the institution I'm pursuing this doctorate at is pioneering action research in the field of kinesiology. So, and I've learned that most people don't even know what action research is. I didn't until a few weeks ago, but this is what it is, and this is kind of what this is all about as well. Action research is you're getting ready to see if you're doing a good job in your business and life in general, you're actually already performing action research. It's mostly just common sense. You identify and define the problem, which is what we're doing here. We've already, and I'll define it further in a couple slides, but we already know that we're defining the problem as there's a gap between medicine, rehab, and fitness and patient referrals, et cetera. So we've clearly defined the problem. So you look at your landscape, you define the problem, you come up with one or more problem statements. What we're doing in our course is then whether you do this would be not being a student or a researcher would be up to you, but you can still do it. Review the literature and gather baseline data. You want to collect the initial data to understand the current state and context of the problem. You then collaborate with participants. So in traditional research, the principal investigator, the researchers, are separate from the participants. You choose or you randomly assign the participants to intervention groups. But with action research, you're an active part of it. Because what you're trying to do is you're trying to improve a local problem. You're trying to improve your profession or whatever the case may be. So you're engaged with the other people, the other participants. In this case, clinicians. Me engaging with clinicians, and clinicians engaging with their patients. Everybody's a participant. You develop a plan of action. So you put your heads together and you develop a plan of action. You then implement it, so this is what we're going to be talking about here tonight. You then analyze the data, and I've got some slides on that because I'm actually currently working with some clinicians who have started this action research process with me. And I'll say right now, and I'm going to say it again, if anyone on this call or anyone watching the recording of this webinar is interested in being involved in this, the more participants for me, the better. So if you're interested in being involved in this, I would really greatly appreciate. But you review and interpret the data, and you look at what were the successes, what were the challenges, what needs to be improved. You reflect. Everybody has a voice, so this isn't just the principal investigator saying, oh, this is what we need to do. Everybody's got a voice. You reflect on it, and then ultimately you revise and continue the cycle. So action research is cyclical, and it's really simple. It's you just look at your situation, you look at the problems, and you collaborate with each other, and you figure out what needs to be improved and how to improve it, and then you improve what you can. You reflect on it, and then you say, okay, here were some other themes that developed that I didn't even think were going to happen. And there were certain things that we didn't improve to the level that we wanted to. So let's now figure out how we're going to get better and continue to improve the process. So that's what action research is. And the way I look at it is if you should be implementing this in life and in your profession, and hopefully you already are and didn't even know that you're performing action research. So here's the problem statement. Barriers to referral to qualified, and the emphasis here on qualified fitness professionals, can range from blah, blah, blah. You can read that for yourself. And all this paints a seemingly daunting picture for clinicians, fitness professionals, and the public, where the landscape includes a nation of ill health in need of the services of fitness professionals with a long list of barriers that prevent this connection. But how are we going to solve it? We can solve it by shifting the landscape, or I'm sorry, the landscape can shift from daunting to promising when you merge two approaches. One, you use deductive reasoning, and you realize that even though there's this landscape of a zillion different barriers, your patient may only have one, two, or three barriers, and they don't have the whole landscape of barriers. So let's just start looking at the barriers individually and then use critical and creative thinking to form potential solutions. And then also, in parallel with that, clinicians should become familiar with motivational interviewing and the stages of change if they aren't already, and then categorize your patients as either pre-contemplative, contemplative, or ready prepared. Because if you do that, then it also creates a less daunting situation because if you're familiar with these with the motivational interviewing, the questions you should ask, how you should probe, etc. When you become familiar with that, then obviously if someone's contemplative, now the whole picture starts to change, and your conversations start to change because they are contemplating exercise, and it becomes easier to move them into ready prepared. And once they're ready prepared, at that point it's just all right, they're ready to go. How are we going to connect? And we're going to talk about pre-contemplative here in a second. So, in other words, and the whole point here is that deconstructing the landscape into its constituent elements through deductive reasoning allows the individual, whether it's the patient or the clinician, to clearly understand each component. Problem solving at this level can demystify the complexity and shift the mindset from a this is how it is and there's not much we can do about it to a this is what we can done, I'm sorry, what can be done perspective, creating a pathway for transformation both for the patient and the clinician. So that's the problem statement and the proposed solutions. And there's one more barrier that needs to be overcome. While patient referrals to fitness professionals have been identified, so if you aren't familiar with the research, there is a ton of research that shows that when you refer to a qualified fitness professional and there's that professional guidance, then the outcomes just significantly improve. So it's been identified as critical for improving public health outcomes. Many patients don't follow through due to inadequately addressed or unaddressed barriers. And additionally, clinicians' lack of trust towards the fitness industry, and it's justified for the most part, combined with a general lack of understanding of how to determine qualifications and how to properly vet fitness professionals, create another barrier to referral that needs to be addressed. The reason why I have that screenshot up there is because I'm really involved in this. I don't have time to get into it today, but I'm involved in this movement at the national and systemic level. And there is an organization called the Physical Activity Alliance, which is driving a movement behind the scenes that most people don't even know about to professionalize the fitness industry so that licensed clinicians can start billing for the services of exercise professionals. That's going to happen in either 2026 or 2027 is absolutely going to happen. And the American College of Sports Medicine is one of the many organizations also involved. And in their current issue, it's a special issue that's out right now, the September-October issue, um, is on this whole movement. And within that issue, there's a feature article, as you can see, called Developing Trusted Collaborative Relationships Between Healthcare Providers and Exercise Professionals. And I was one of the co-authors, along with Dr. Amy Bantham, who's the immediate past president of the Physical Activity Alliance, and Dr. Matthew Campert, who is at the Cleveland Clinic. So again, I'm involved in this at the national level and just beyond passionate about it. So let's start breaking this down now. What are the steps in this stage-based model that I'm proposing? Number one, ideally, you'd want to begin with intake forms, and more on that in some future slides. But if you have uh, the right intake forms, that really sets things up with your patients in the clinic, because now these intake forms, as you're getting ready to see in upcoming slides, can really help you determine before you even speak with them, or as maybe they've already been a patient and now you have them fill out these intake forms, where they're at. both from a fitness standpoint, from a mindset standpoint, from a behavior standpoint, everything. So we want to begin with intake forms. Use the intake forms to become familiar with which patients are candidates for referral. Become familiar with the solutions to perceived barriers, which we're going to talk about a little bit tonight, and allow those solutions to help guide conversations. In other words, use use all this to deconstruct the seemingly daunting landscape. And number four, become familiar with optimizing the connection to fitness professionals for patients who are ready and prepared to exercise. So those are the four steps. So let's go through them one by one. Intake forms. If you're not aware, and this is a screenshot of the non-exercise estimation of aerobic capacity, or VO2 max, using the IPAQ, the International Physical Activity Questionnaire. So I have been contracted out by a medical group here in New York City, and it's a they're launching a telehealth um, program basically, and they contracted me out to create intake forms, and then to use the intake forms to categorize patients as either beginner, novice, or intermediate. And so if anyone on this call, or on the webinar live or watching the recording, is interested in something like this and me collaborating with you, because I was contracted out and I'm willing to help a million practices if I can, then we can work on this. But the reason why I bring that up is because this is one of the things we did with the intake form. We use this questionnaire, and I'll show you some of the questions on it. But we use the questionnaire to start to dig deep and to get a sense of what's their aerobic capacity. Obviously, it's not as ideal as a treadmill stress test or some submaximal field test, but this is validated. So it is a way to get at least a strong idea of where they're at from an aerobic capacity standpoint. So obviously, this IPAC can be used to assess their aerobic capacity, their aerobic fitness. But then what I did with this intake form is dig even deeper and had questions related to what is the patient, what's your perceived aerobic fitness? What are your barriers to aerobic exercise if you aren't currently performing it? What's your interest in increasing aerobic fitness if that applies to you? What are your goals, etc.? So the point is that we created this intake form to start digging deeper than just this questionnaire to determine their aerobic fitness. And then there's also one for muscle strengthening. Now, this doesn't determine muscle strength. It's more of a what are your habits type of questionnaire. But just to make you aware, the muscle strengthening exercise questionnaire, an assessment of concurrent validity and test retest reliability. So this gets into just, what's the frequency of your muscle strengthening, kind of that fit principle stuff. But again, with the intake form that I created with this medical group, dug deeper and and probed more things. What is your perceived strength fitness? Um, Elise, is Andrew Mock on the call? Do you see him on? Okay, so I was really hoping I collaborate with a doctor named Dr. Andrew Mock, who's licensed in board certified in family, lifestyle, preventive, and obesity medicine. He's also a five-time strongman champion, and we're getting ready to present at the ACLM conference at the end of this month, and then again 3 weeks later in New Orleans for the Medical Fitness Association. But we just had him on our medical fitness podcast, and one of the things he talked about in the podcast was that he likes to do basically the eye test. Yeah, we can use all this research-based stuff, but we also have the eye test and can just many times just look at somebody and tell, or at least get a strong sense of their fitness level. So he uses the sit to stand assessment as not only the eye test, but also he'll use it as a way to begin the intervention. So if they're struggling to stand, up and down from a chair 6 or 8 times, and they're already starting to struggle to get up, or they need to use their hands or whatever, he uses it as a teaching tool. And he also uses it as a way to say, like, for example, if the patient was able to get 8 repetitions, but by their eighth one, they're starting to get that look of strain on their face, and the speed of the movement is slowing, he'll use that as a way to say, this is actually the level that we want to be at in order to know that the intensity is high enough to elicit adaptations like strength or whatever. So in any case, but you get the point here. You create intake forms. They can be detailed or as detailed as you want, but make them multifactorial or multifaceted so that we can start digging deep into barriers and your access to equipment, et cetera. It really sets up the conversations with your patients that much easier by doing it this way. And then you can also ask on the intake form questions related to how frequently are you exercising? What's your perceived intensity? How hard do you think you're exercising when you're doing strength training for those who are actually doing it? How long do you spend in your sessions? How many sets are you doing? Do you progress? What are your goals, et cetera, et cetera? So start with intake forms. Which patients are candidates for referral? And we'll have time for discussion so that you can, if you want to discuss it, if you disagree with me on anything, we can discuss it. But here's my answer. Pretty much everyone, pretty much all your patients are potential referrals to fitness professionals. And there's really only two categories that don't apply. If you, as a clinician, know that your patient has a severe or uncontrolled condition that needs immediate medical condition, attention, then obviously they don't apply. And so I'm not talking about them. And I'm also not talking about the patients who you know are currently on a structured, progressive resistance training program. But that's going to be few and far between for two reasons. Number one, hardly anyone is on a structured, progressive, properly designed resistance training program because hardly anyone's even meeting the minimum guidelines for strength training and resistance training. That's number one. Number two, the clinician themselves would need to be would need to understand what that even means and then to talk with their patient about that if you even have the time, which in most cases you don't. So, so kind of the point here is that we resistance training is supposed to be, we tend to know intuitively, I'd like to think that aerobic exercise should be lifelong, but so should resistance training for everybody. It's part of the WHO guidelines, CDC, ACSM. It's part of the guidelines. Everyone should be strength training lifelong. As a matter of fact, the older you get, the more important it becomes to be on a resistance training program. So, because of that, we need to consider pretty much everyone a candidate for referral, with those two exceptions. But with that said, and I think this is really important, and it's why I included this in the webinar. In most cases, they only need to get started on the right path. In fact, for most people, being referred to a fitness professional makes them feel like this needs to be for the long term. And it's a barrier to referral because in their head, they're thinking, "Oh, I can't afford it. I don't want to train for a train with a trainer for the next 3 months, 6 months, a year, 2, 3 years of my life." It's a barrier to referral. Again, I've been staff at Duke, Mount Sinai, Beth Israel, UCLA, and it has become very clear to me that at least 90% of patients who have been referred to me across my career were not looking to train with me or a fitness professional long term. 90% or more, that many. Most of them just wanted to know how to get started off on the right foot with a clinically safe program, understand proper form, etc. So more on that when I talk about our virtual services. But it's important to understand that. Patients should be informed that a potential better option exists. Work with a qualified fitness professional only for as long as it takes to understand how to exercise safely and appropriate for their local situation. In many cases, this can be as few as 5 to 10 sessions, followed by an occasional check-in to progress the program. And this is also, I'm going to blame the fitness industry. The fitness industry is all about we need to entertain our clients. We need to retain our clients. And it's all about doing that rather than just let's teach them how to fish and then let them go fish. And if we were doing that and clinicians were referring, then we'd have a nice model set up so that it wouldn't matter that when a patient drops off because they're done their 10 sessions with you or whatever, because here comes the next one. And that's what I experienced when I was at Mount Sinai and Beth Israel. So it's a model that's not even being considered, and it needs to be considered by both sides of the fence, clinicians and fitness professionals. So now let's start to address the stages of change. So again, we start with like some prerequisites here, some general knowledge on the behavioral change and motivational interviewing, general knowledge on exercise and programming so that you can better speak with your patients. So there are some prerequisites. And then we start with ideally with the intake form. And then now it's time. Now they filled out their intake form and now you have some starter points. You've read it and you're like, oh, okay. So now I understand their barriers, blah, blah, blah. So now it's a matter of how do you address each stage of change? And here's where we're going to get into a little bit of discussion. Again, we've already noted which pre-contemplative patients are obviously not candidates for referral, so I'm not referring to them. And we need to understand and consider that many patients seem pre-contemplative, and I really do mean many. Many patients seem pre-contemplative, but it's primarily because they're either uninformed or misinformed. And this is where the knowledge of the clinician on taking perceived barriers and actually turning them into facilitators so instead of being barriers, they can actually become facilitators to exercise and or referral to fitness professionals. So let's really quickly discuss or at least address some common barriers. Lack of time. If someone wants to just quickly chime in, and what is a at least one solution for the perceived barrier of I don't have the time? How would you address that with your patient? And I know and Sheila, I can see you, and I know you got the smile on your face, so I know I'm definitely going to let you chime in on this one, just so that we can keep moving. If no one chimes in within like 5 or 10 seconds, then I'll either answer or like Sheila or Elise answer or whatever. But Sheila, go ahead. This is one of your favorites. By the way, real quick, Sheila is again, she's a friend, colleague, business partner, physician assistant. She's amazing. She's a fellow in the American College of Lifestyle Medicine. She chairs their physician assistant member interest group. So with that as a background,
Yeah, one of my biggest favorite things to talk about with these patients is the concept of snacks. They're all familiar with snacking in the nutrition world. And if they don't have time for a meal, they grab a snack. So if we don't have time for an exercise session, what do you think about an exercise snack? I've had 100% yes, I can do that. An exercise snack. How long does it have to be? I'm like, it's a snack. It can be 2 minutes. It can be standing like a 10 sit to stands. Just when you get up to go to the bathroom, get up and sit down 10 times and then go to the bathroom. Very simple. And then when they get success with that, they increase their self-efficacy and are interested in, well, what else can I do? What other kinds of snacks can I try?
yeah, and I'm going to chime in and say I'm glad you ended with that because we always have to think about down the road. You start with where they're at, and you understand that exercise is built on principle of progression and overload. And you just and you also like since I'm on the side of the fence of training, coaching, etc., that it's very clear to me, learning through experience, that one minute they don't think they can lift more than 10 pounds or they don't think they're capable of such and such, and literally a month later they can't even believe that they're doing 1.5 times that or double that or whatever. So I think clinicians, and again, I know I'm painting a broad brush here and I know it's not completely fair, but just to get my point across, I just wish that it was more common understanding in the medical and rehab world, especially the medical world, that yeah, just because they have a certain capacity now doesn't mean they're going to have that exact same capacity and motivation a month from now, 2 months from now, 3 months from now. So we can keep progressing, especially if it's with a qualified fitness professional and a properly designed program. Let's go to the next one. What do we do with someone who's just uninterested, lack of motivation? What does the conversation look like? What can you say? Anyone want to chime in?
Jeff, I'll monitor the chat. We had some people chime in last time with pretty much what Sheila alluded to with start small and slow,
Good.
working it into your day. So that
Good.
definitely on target with the exercise snacks. And somebody right now just said link it to their why regarding why there may be a lack of motivation. Someone else or same.
Real quick, I know Sheila is huge on that, so we talked about that recently, so that's great.
Yep. And D is the person who said that regarding link it to their why and just elaborating it to connecting it to their dreams and their future. You also have somebody else who said asking them what motivates them and then tie that back into their motivation.
Good. Let's keep going. Lack of money. I don't have the fun. I can't afford it. I don't have the finances. How do you address this? Is it a true barrier every single time, or is it just a perceived barrier?
I think it's a perceived barrier. And what I do when patients, I mean, I know they're thinking about the lack of money. What I always do is I ask them when their birthday is. And they go, oh, my birthday is November 11th. So I said, well, why don't you buy yourself an advanced birthday present and buy yourself 10 sessions with a trainer? And a lot of them like that because it's almost like, oh, I'm going to do something for me.
Yep, love it. Absolutely love it. Sheila, you chime in on this one.
Oh, well, I ask patients what they like to do, and a lot of times the things they name don't even cost money. So it's very bizarre that lack of money is one of the things they list as a barrier if, they're interested in, they love nature walks or their stationary bicycle that they have in the basement, or YouTube, exercise videos. There's a lot of ways to work around the money thing.
And I'll add one more before we move on to the next one. Um, Sheila and Thomas, the physical therapist colleague, and I co-presented 2 years ago at the ACLM's annual conference in Orlando. It was a 3-hour pre-conference presentation on how to basically everything we could fit in 3 hours on how to move patients through the medicine rehab pathway into the fitness domain. And we actually have a course up on our site that's pretty much verbatim what we talked about in video form. But one of the things that Sheila and Thomas talked about was, and Sheila, you chime in here, or correct me if I'm wrong, but for the most part, it's not the clinician's job to even determine whether, don't even worry about it. Unless you know for a fact, you're not their financial advisor. Unless you somehow know for a fact that they just literally can't afford their electric or water bill or whatever, that's it's actually going to save them money, right? By getting healthier and demedicating or whatever the case may be. And it's just so important to get them exercising. Again, the fitness trainer doesn't have to be long term. It could be 5 or 10 session investment, like Scott just mentioned or alluded to. So just get them to us for the initial consultation, and we'll take it from there. That's part of the answer to the question.
And
Get
Jeff, may I say something?
Absolutely.
Also, for lack of time, I don't know if this is counterproductive, but what I tell them, if they say they don't have time, I say that if you don't have time, you'll make time for getting sick. You're going to the doctor a lot, you're going to the pharmacy, you're going to physical therapy, you're going to the you're going to have tests. That's a lot of time.
Yep. And actually, on that note, Amy Bantham, who I co-authored that article with, who's a past president of the Physical Activity Alliance, and her doctorate is in public health from Harvard, and she did her dissertation on this. And it's an amazing 100-page, but it's an amazing article, and this was addressed. She's up in the Boston area and worked with several healthcare facilities up there. And what you just said was addressed as part of her dissertation. It's in her article. So yeah, it's a great point. But again, just for sake of time, let's keep going. And actually, part of my point here is there's not just one answer. I'm glad that we're coming up with different answers. It's not just one answer for each perceived barrier. It's maybe a whole bunch. And so therefore there's a learning curve and a need to become more dive deeper into this stuff. Sheila and Thomas, who are just amazing at motivational interviewing, are going to have their own webinar on this sometime in the near future. So we will absolutely be diving deeper into all of these topics. But what about the belief that exercise needs to be hard and sessions need to be long? And I'll just for sake of time, I'll address this one. Absolutely not. As a matter of fact, a properly designed program should ebb and flow higher intensity, lower intensity, higher volume, lower volume. We do not want the body and the mind cannot sustain high intensity, period. And so people who it's a barrier to exercise because they think the sessions always need to be hard. They think you need to be sweaty. They think you need to be sore. They think it needs to be an hour long. And this is where clinicians, if they're educated on periodization and proper programming, which again I can absolutely and want to help with, I want to help you with this, then you'll start to understand, oh, within the scope of each week, we actually kind of need to have sessions that are lighter to give the mind and the body a break. So some sessions are a little harder and some that are a little lighter within the scope of every single week. Some sessions are a little harder and some that are a little lighter. And also within the scope of a year, you should take breaks from exercise. They really shouldn't be any more than about a week in length, but give your body and your mind a break. So again, a lot of times just having these types of conversations, the light bulb will go off in the head of the patient. Ah, I didn't know that. You mean I don't need to sweat? I don't need to be sore? I don't need to go for an hour? Absolutely not. And you can quickly move them from pre-contemplative to at least contemplative. So that's part of the point here. couple more or a few more examples. Don't want to exercise in a gym or health club? We'll put you on a home exercise program. Don't worry about it. Joint pain, low back, knee, shoulder. Scott knows this as a physiatrist. I know there's a physical therapist on here. Hey, there's joint friendly exercises. We'll just, your low back and your knees hurting. We'll do some supine bridges or something like that. Some straight leg raises. We can do things that will still strengthen you and exercise you, and not only will not hurt your low back and your knee, but they'll actually be beneficial for your low back and your knee, and you'll be feeling better. Shoulder, just staying in the safe zone, and we will avoid overhead presses and things like that. We will just, do scaptions and blah, blah, blah. But the point is that when the clinician is educated that, no, this is actually a facilitator to exercise and not a barrier, and the person can quickly move from pre-contemplative to least contemplative just by becoming informed. And they just were either uninformed or they were misinformed. Just by informing them, boom, you just moved them into a better stage and out of pre-contemplative. Apprehensions, fear of judgment, fear of failure, fear of getting injured, fear of judgment, home exercise program. Fear of failure, a good trainer is going to make you feel successful literally from session number 1. So you're going to go from a fear of failure to the trainer or the fitness professional is going to be, showing you what you're capable of that you didn't realize, and that's going to switch just like that. And fear of getting injured, on a properly designed program, you're not going to get injured. You're actually going to significantly decrease the risk of injury, because your tissue is going to increase its capacity to tolerate stresses. um, uh, you're going to be more fit, et cetera, et cetera. So again, so many of these uh, barriers that place people into a pre-contemplative state of mind are actually can be flipped around like that into facilitators for referral. Chronic pain, same situation. Chronic fatigue, exercise is actually going to help those things. Motivational interviewing questions. Sheila, you can tell me, since you're more of a pro on this than I ever am. I actually stole this stuff from the. And by the way, for I'm happy to pass on the PowerPoint for those of you who are interested in it. If you don't want to take too many notes or whatever, but what do you think about these? Were these accurate, Sheila, for the most part, for pre-contemplative stage?
Yes, I like this. I also like to ask these people if there's any type of physical activity they would like to be able to do, but currently cannot.
Okay. So yeah, these are just examples. This is definitely not a comprehensive list. Sheila and Thomas will be diving deeper into all this, and we can continue to have um, uh, webinars to dive deeper in all this. So right now, today is mostly just a high level view, and we'll keep going as long as there's interest. And then other options for people who are pre-contemplative is let's just get them informed. Again, the MRF Institute has educational videos, and let's just create an informed consumer. That's my tagline. This huge reason for a lack of exercise in the United States is people are, with all those myths and fads and gimmicks and crap that's out there, then it turns people off. And if you just create an informed consumer, what an effect it would have on public health. So we have educational videos that can help inform. Shared medical appointments, which Sheila is a master at, and we'll be having webinars on this as well, is something to consider. Telehealth, having an exercise specialist and join telehealth visits if that's part of your practice, and also support groups. Look at the world we live in. We literally tonight could create a support group on Facebook or LinkedIn or something like that, and by tomorrow you could be referring your clinician, your patients to it, and we have a support group that you can be involved with, uh, and basically just have subject matter experts across the spectrum of care: physiatry, physical therapy, um, physician assistant, exercise specialist, etc. And what a great thing that would be for a patient. So that's other things to think of. We have to think outside of the box. What's traditional is not working, so we got to think outside of the box. So the point again is creating informed consumers often makes patients realize that their barrier to exercise was perceived and has one or more solutions, and they can many times be successfully moved quickly to the contemplative or ready prepared stage. That's the point of all that. Let's keep going. Contemplate. We can move through this stuff much more quickly. What do you think about these questions, Sheila? Again, I stole these from the internet. what would motivate you to start exercising, and what are some things that have prevented you from starting an exercise routine for those who are in the contemplative stage?
That's great. You want to pull out pros and cons and any barriers.
Anything to add? Yeah. Okay, good. And now ready, prepared. Hey, at this point, they're ready and they're prepared. So let's go. Let's get them going. So now, from a clinician standpoint, and again, today's webinar is, yeah, we want to get them exercising, but I'm here trying to let's get them connected to a fitness professional again, even if it's just for those first 5 to 10 sessions and then some check-ins afterwards. Because especially with resistance training, there needs to be hand holding in most cases, because it's not so easy as the fit VP principle. It's how often you're going to do it, how many sets, how many reps, how do you determine the weights you're going to choose, for each exercise, what's the order of exercise, how long do I rest, how long do I strengthen muscle groups, I'm sorry, how many times in the scope of a week. There's many more questions and things that are involved in designing a program. So that's just another reason why medicine and rehab need to connect with fitness as long as they're qualified. So in person, it's really, there's just be aware that there's registries that exist. The United States Registry of Exercise Professionals is a giant registry of like over 100,000, I believe, fitness professionals across the country. It's not the greatest database. By the way, I actually I have a video, and if you want, email me afterwards and say, hey, you said you have a video on this, on how to make the connection in person. Can you pass that along to me? And I will pass it along to you. I go into a lot of detail about the vetting process, registries, and comparing and contrasting US reps with the National Strength and Conditioning Association's registry and database, the American College of Sports Medicine, and the American Council on Exercise. And you'll see that there are really big differences between them. Some aren't so good and some are much better, etc. And another thing, I was really hoping that Andrew Mock would join, because again, we just had him on our podcast and he talked about this, that the clinician, if possible, go to your local gym or health club. And that's what he does. And get to know the trainers. You know, again, I can help you over the course of time with the knowledge that you're not going there uninformed. And but if you know your basic exercise principles and stuff like that, and you know how to vet, go to the gym and talk to the manager, and maybe even join the gym and gets a consultation, or some training sessions or something like that. But there's definitely ways that you can connect other than just registries, unless obviously you live in a rural area. But in that case, that's where virtual training comes in. And then virtually, which I'll talk about a little bit more detail in a few minutes. But yes, at the Medicine Rehab Fitness Institute, we have, or I have created a virtual medical fitness service. Again, it's because during the pandemic, the light bulb went off in my head when everything was going virtual, because we were all stuck inside, and the light bulb went off in my head. Wait a second. Most of the patients who have been referred to me over my career were not looking for trainers long term. And this is actually a perfect opportunity, because we take travel as a barrier out of the equation. We make it that much more affordable, because you don't have to charge as much because it's virtual. Um, and the whole, you only need to purchase a consultation and maybe one or more 5 packs, and then you can do check-ins if you want after that. So it's just much more affordable. And as you're getting ready to see in the very last slides, there's research to back this up as well. There's plenty of research to show how successful virtual services are across older adults, those living with obesity, et cetera, et cetera. So let me just very quickly go through what this action research. So again, I'm in this course right now in a doctoral program called Action Research in Kinesiology, and I am 1 week into the data collection. So I'm still a newbie with this as well. Although since I'm so far into my career, it's easy for my mind to grasp it. I can tell with some of my classmates, and being earlier in the career, it's not quite as easy for them, but I have so much practical experience that this is easy for me to grasp. But this was the gist of it. First of all, um, the clinicians that I'm working with, and it's just a few right now, they create an Excel spreadsheet, and because for like HIPAA, there was no name or address or phone number or anything like that. It was just gender, age, and then those what is this, 5 columns. And more on this in a second. So this is the data that I was asking them to collect. And again, if you're here, watching this and you want to be involved, it will be really helpful for me because it's going to be ongoing. And if you're watching the webinar and you're interested, please email me because this is going to be ongoing. I'm actually kind of using this as a pilot, and then I'm going to be doing my main dissertation, and it's going to either revolve around this or it's going to significantly include it. So basically, I asked them, and I'm asking you if you're interested, select 2 to 3 patients per day. It actually could be one, whatever fits into your local situation, but select 2 to 3 patients per day to participate in this study. And if possible, it doesn't have to be this way, but if possible, focus on patients who are likely to benefit from a referral to a fitness professional, i.e., those who are in the contemplative or readiness prepared stage, which again, if you're using intake forms, which I'm happy to help you with, if you're willing to collaborate with me, then that's really going to help the process of determining what stage they're in, along with your conversations in the clinic. I also asked them, what are the common themes and this is, in other words, this is the data that I wanted to collect. What are the common themes and patterns that you're seeing, that you're hearing from your patients? What are they commonly saying? Is it motivation? Is it money? Is it lack of time? I'm just very interested in what are the 3 or 4 most common barriers, and just put that in your end of the week log that you would then send to me. And again, what I'm doing right now is end of week. If I'm collaborating with you, then we could make it each week, bi-monthly, at the end of the month, whatever fits into your local situation. It doesn't have to be exactly like this. How do you address the barriers? What does the conversation look like? Here, again, we're only 1 week into it, and this is an example of one clinician. I'm working with several. This is one, and I actually, and this is what she wrote down in her columns. Contemplative stayed in contemplative. They ended the appointment, felt like they moved to contemplative, so they moved them. I mean, to me, this is even though many of them stayed, I think it's amazing that in 1 week with one clinician, and we're all new to this, we're already able to move people. And uh, in a couple of weeks, we're going to do a reflection, since that's what action research is all about as well. So we're going to have like a debrief, and hopefully then this will be ongoing, and we'll have occasional debriefs, which again, if you want to work with me, I'd like to do this with you as well. And so it'll be interesting for me to hear, because everyone should have a voice. I want to hear how they went about it, but then I'm going to have a voice and say, oh, well, what if maybe we incorporated this? Or if we incorporated this, it might strengthen the the process of moving patients through the stages of change. But in any case, they also on the Excel spreadsheet, and I just put it in bullet form. Common barriers were stress, and the discussions included benefits of movement and exercise for stress. Another common one was injury, and this particular clinician discussed options for working with a physical therapist, which is great. Medicine, rehab, fitness. Discuss time management. So it was interesting that they didn't put exercise snacks, so I might speak with them about snacks just as another option if they're not aware. Motivation, they discussed SMART goals. Financial, they discussed and reviewed free resources, etc. So we're only 1 week into this, and this is already really cool. And I can only imagine how much cooler it would get if I was working with that many more clinicians across the country, and um, the data was, getting large. The data sets were getting larger and larger. So let's start wrapping this up now with qualifications to look for in a fitness professional. And by the way, I'm happy to go a little over an hour. If you all need to drop off, that's totally fine. I can go a little over an hour, not too much over an hour, but I can definitely go. So qualifications. There's credentials and there's competence, and they can definitely be 2 very different things. Just because someone has credentials doesn't necessarily mean they're competent. And in order to determine their competency, this is where the vetting process comes in. And the vetting process has different stages and phases, which I'll talk about in a second. From a credential standpoint, and I'm just talking about if I were a clinician, I would definitely want the exercise specialist that I'm referring patients to have a degree. That's my bias. A degree in exercise science, kinesiology, or a related field. And then there's a zillion certifications, but they absolutely lie on a totem pole. There's 2 governing bodies, as I previously mentioned, in exercise science: the American College of Sports Medicine, or ACSM, and the National Strength and Conditioning Association, or NSCA. Their certifications are more rigorous, standards are higher, and I would definitely look for a exercise specialist who not only has a degree in exercise science or related field, but certification through one or both of those organizations. The ACSM's pendulum tends to swing a little bit too far, in my opinion, towards the clinical side. Not that that's a bad thing, but they tend to, it tends to be some underdosing going on in their suggestions and guidelines. And just for whatever, I'm past president of the ACSM's Greater New York Regional Chapter, so I'm not anti-ACSM. I'm just calling it how I see it. And the National Strength and Conditioning Association, which I'm very involved with, um, their pendulum swings a little too far, in my opinion, towards the athletic side. And I just think that both, if we could just take both of those and mix them, which is actually what I did with the Medicine Rehab Fitness Institute and 30 years of experience, um, then we have a really nice sweet spot and a nice mix. Let's mix the clinical side with the strength and conditioning side, and now we have a great mix. But from a competence standpoint and experience, this is where, from a clinician's standpoint, you have to have the time, the desire, and the knowledge to perform an interview, because that's how you're going to vet, right? The way you vet is to interview. And sure, you can go, like, for example, the American Council on Exercise, which is one of the largest. So again, let me backtrack for a second. I mentioned that there are a zillion certifications, and that at the top of the list is the ACSM and NSCA. After them, there's a gap, in my opinion. I'm giving you my opinion. And then there's two more that are towards the top of the totem pole, but it's a gap. And those are the American Council on Exercise, or ACE, and the National Academy of Sports Medicine. Those are far and away the largest health club certification. So from a membership standpoint, these are the two largest fitness certifying organizations that exist in the world. Um, Using ACE as an example, if you went to their website and go to their registry, I actually think it's really clinician friendly. You got a nice headshot. You have their zip code or the areas they work in. You have how much they charge, their experience, their certifications. You have a bio. It's got all the information you need, but a lot of them are not certified. I'm sorry, not a lot of them don't have degrees in exercise science. So you have to dig a little deeper to find someone with a degree. Not that they don't, it's just that a lot don't. So anyway, but it takes time from a clinician standpoint. And I've been, again, most of my career has been working in clinical settings. So I'm fully aware that many clinicians just don't have the time. So if you do have the time to vet, I am happy to help you. And we can set up a Zoom call, email exchanges, whatever you need, if you have the time. But please understand that from my perspective, and for purposes of this webinar, you're actually an outlier. If you have the time, you're an outlier. And first of all, good for you. I think it's awesome, because you should vet and know how to vet, etc. But part of what I'm leading to is I'll do the vetting. The Medicine Rehab Fitness Institute will do the vetting. So more on that in a second. So we'll take that job away if you want, but more on that in a second. So the MRF Institute, we are launching a MRF Institute certificate. So bear with me here. You have an exercise specialist who has a degree in exercise science, and you know that through whatever the information they gave you through an email or something like that. Hey, my name's John Smith, and I have a degree in exercise science, and I'm certified through the ACSM and NSCA, and I've got 10 years of experience, and you should refer your patients to me, etc. That all sounds good, and if you want to believe them, go for it. But the way I look at it is, the MRF Institute certificate is going to be another layer for you to help. We can't ever really truly prove that they're as competent as it gets, but this is another layer of safety. So I have written I've co-authored a book called The Medical Fitness Bible, um, with Dr. John Bonnet, who is board certified in family, sports, obesity, and lifestyle medicine, and has a master's of public health from Harvard. And he's amazing. And he's also a certified fitness trainer. And I've known him for almost a decade, and he's absolutely amazing. And we co-authored a book called The Medical Fitness Bible, and there's corresponding videos. And these are all actually approved for credits for fitness professionals through the National Academy of Sports Medicine. So these are accredited courses, and so it's a win-win for everybody, because the fitness trainer will pay for them, but they're also going to apply to their continuing education for their certification. So um and I have a meeting tomorrow, which I can't really divulge too much right now, but the meeting which I will be able to divulge in the next related webinar, is actually going to take this to even a higher level than it already is. And one last thing, those videos that I created, again, please keep in mind, I teach strength and conditioning for an exercise science program. I teach sports medicine and rehabilitation, and I actually merge those two in my classes. I teach weight training and I teach nutrition and health. So um, this course is really like getting an undergraduate level course, and the videos are I created actually for a corporation called LNG Canada. LNG stands for liquid natural gas. Shell Oil is the parent company. This is a $40 billion corporation, and they brought me on as a contractor to do this kind of stuff. So it's as legit as it gets, and it's something for you to at least keep in mind as another layer of of basically helping to ensure competency. So let me and the Medicine Rehab Fitness Institute do this for you, even if it's local trainers and you're training in person. In my biased opinion, you should still be sending them our way and having them purchase the Medical Fitness Bible and the videos, because again, they're still going to get CEUs for them, and it's going to help with you to know that if they passed our exam, then there's going to be an extra layer of competency in there. You can be much more ensured that they're going to understand how to design programs for people across the spectrum of medical conditions and across the spectrum of musculoskeletal conditions. So these slides I'm not really going to spend any time on, because we got to wrap this up. But there are benefits to virtual training, obviously professional guidance that people need. So in other words, the way I look at it is, virtual training can be really beneficial for your patients, and you will actually capture a very large subset of your patients that you're not even aware of if you aren't using these types of services. You can capture a large subset of your patients, or at least a subset of your patients. Let's take away the word large. Even if it's only 10% or 5% or 15, it's at least a subset of your patients that otherwise wouldn't be captured and may not be put on a strength training program. So think of it that way. This is an option that I think that yeah, I'm biased, but I think just from a public health standpoint and from your practice standpoint, every clinician should be incorporating virtual services into their patient services, just so that there's another option within the a la carte that you're offering your patients. So it's cost effective, can be short term. There's plenty of studies, and these are just some studies on the efficacy of virtual training. So uh, Elise Freeman, who, because I've been yapping, have not had the chance to formally introduce, and I will here in a second, because this is really the last slide, and then I'm going to introduce Elise, and then wrap this up with any questions or comments. But if anyone's watching this live or the recording, and you're interested in collaborating with my action research project, it would be extremely helpful, because right now it's in pilot stage, but I really want to use this for my primary dissertation. So it would be really helpful if this is something you're interested in. And I've already gotten the feedback from the clinicians who are helping me that it fits well into their workflow. And yeah, it's a little bit of extra time with writing things down, but again, we can modify that for your local situation. It doesn't have to be every single week if you don't want to, but they really like the data collection and being involved with a research project, etc. So if you're interested, please send me an email. It would be really helpful, and I'd really appreciate it. And if you're interested in any other type of collaboration, if for example you have a clinic and you're thinking about adding um, uh, medical fitness services at your clinic, and you want help to hire a fitness manager and trainers and stuff like that with the vetting process, or anything that involves medical fitness, please think outside the box. Connect with me. I'm happy to help. So with all that said, Elise Freeman is someone that I met several years ago. I'm going to let her introduce herself, but she is one of the primary trainers for my virtual medical service. So Elise, go ahead and introduce yourself. She's amazing.
All right, so hello everyone. So as Jeff said, I am the primary trainer. So I work with a lot of the referrals, a lot of the patients that you all refer to us. And so my experience is basically once you guys all refer them to us, we go through a consultation process. And so it allows me to get more insight and information about the patients that you all refer. We, in that process, could also get information from you, the clinician or doctor in general, just to provide us some basic insight. Insight from your perspective combined with the insight from the patient's perspective. So that way it could be a little subjective and objective on both ends. From that, after we do that consultation, we also have an intake form, just like Jeff mentioned. And within that intake form, I use that information to help me gather the details that I need to see where they are when it comes to their readiness. Obviously, if they're now speaking to me, we have a consultation. It lets me know that they're ready to some form or fashion. And so that's a really great thing. From there, we're able to build up from that stage of the game. And so after we build everything up, when it comes to like their confidence, figuring out how many days per week they want to exercise, their exercise environment. So if it's going to be at home or in a gym, then we're able to build a program for them specifically. And so with that program that we build out, everything is tailored to them. The one thing that's really, really cool is no matter where they go, I can accommodate. So if they say they're going on a trip to Hawaii, then I say, all right, when you get to Hawaii, just send me a video of the gym. And then based on the video that they send me, then I'm able to construct a program for them that's specifically tailored to where they are. So it doesn't matter where they are or any type of barriers. We can always address those items and then create a program for them based on what they have access to. If they don't have access to anything, I say, okay, well, let's pack some bands. And so then we'll work with those resistance bands. So that way we don't have any breaks in their program. And one thing that I always get as a piece of information is that there's an additional layer of accountability. And so accountability is the biggest thing. So even with someone who I was meeting with today, so we had a little week off just because of some transitions in our schedule. But her biggest comment to me was, if I didn't have to see you face to face, I probably wouldn't have done it. So knowing that she had to come and see me face to face, it allowed her that extra motivation to continue on because she didn't want to necessarily disappoint herself and not have anything to say nor disappoint me. So that's just another layer of accountability and something that's just very beautiful about this process with training clients online and in this virtual aspect. But overall, just give a little bit more insight about my background. My degree is in exercise science. I did kinesiology through and through for my bachelor's degree program. I did physical education with the emphasis in pre-physical therapy. For my master's degree program, I took the exercise science route. I also am a certified personal trainer, and I have a concentration in strength training as well. So that's my background overall. I really enjoy everything that I do. I'm very passionate about it, and I'll let that be my spiel right now, so we can open it up for a little bit of a Q&A.
Yeah, and let me add one more thing. She recently moved from the giant state of California to the giant state of Texas very recently. And while
Yeah.
she was in California, she was a an adjunct lecturer for in the California State University system. So she's doesn't just hold a master's and with her experience and everything, but she is a teacher as well, and she's absolutely amazing. And Sheila can attest to that as well.
Yeah, I was just going to chime in as a clinician who refers to the virtual fitness service. The feedback I get from patients is fantastic. That's why I keep referring. I've had some patients who went in with for a 5-pack and have told me they continue to see Elise every month to have her help continue to progress their program because they're seeing so much progress. I have one in particular who's winning tennis games because of her strength training program with Elise. So that's my 2 cents.
Yeah. So yeah, so please send me an email, go to our website, follow me on social media, check out our medical fitness podcast because we honestly have heavy hitter after heavy hitter after heavy hitter on our podcast. And we actually have guests lined up through much of 2025. And a lot of it is because we've partnered with the Medical Fitness Association. So it's a legit podcast. And then we also have a Medicine Rehab Fitness Institute Facebook page. So just go to the search box and just type in Medicine Rehab Fitness Institute, and please join our community, which is a growing community that is mostly clinicians across a wide spectrum of care, and it's just an opportunity for you to network, collaborate, ask questions, get answers in almost real time, etc. So with that said, I'm going to do a stop share and ask if is there anyone who has any questions, comments, concerns, or and actually another thing that'd be interesting for me is when I have part two, whether it's in the chat box or right now or through email later, what would you like for me to include in a part two webinar?
I have a a request.
Sure.
So my biggest need is first of all, I see a lot of geriatric. I would say maybe 50% of my patients are geriatric, and they come to me with back pain, and a lot of them don't do any strength training. And when I talk about exercise, a lot of them say, "Well, I walk," which is great, but nobody lifts weights. Okay, and a lot of my patients have osteoporosis, and they see me because they have compression fractures, et cetera, et cetera. So their doctors put them on Prolia, they put them on all kinds of medications to increase bone density, which is fabulous, but I think there needs to be the exercise synergy, and that's where I need help. I need help how to get them started on a uh, uh, weightlifting or resistance training exercise program to build bone density, and that's what I need.
Okay. The short of that, and we'll definitely dive deeper, but the short of that is you start with a very like, for instance, if you were refer someone like that to me, um, from a programming standpoint, you start them off on a very physical therapy like program. Even if, like, again, you and I talked before this got started, and so you know that I've spent the last 20 years working along physiatrists, and many times after they got trust in me and knew I wasn't going to hurt their patients, many times they'd actually bypass physical therapy and send them directly to me, if they felt like the patient would benefit a little bit more from starting right away on strength training and a total body program. But part of my point here is if that was the case and you referred somebody to me, even still, I would start them on a very physical therapy like approach in the sense of 2 or 3 sets of 10, low volume, low variety, low intensity, just warm up intensity, etc. And just it's called a familiarization phase, and you just use that short phase to determine their appropriate exercises, their pain-free range of motion, teach them proper form, et cetera, et cetera. And then slowly at their pace, slowly start to increase really mostly just the intensity. You kind of keep everything else the same for the most part during that phase and just slowly move it from warm-up sets to true working sets, which I can tell you about what that means in the future. But you want to guide them from warm up to true working set intensity, and then from there you put them on a program that is ACSM and NSCA guided, where you kind of start with lighter weights, and then over the course of time, in tolerable increments, because the tortoise wins the race, you just start going a little bit heavier and a little bit heavier. Um, and again, I've developed and led osteoporosis programs, and geriatrics has really been primarily like that's my comfort zone, basically from 55 to 90 plus and everything in between. So that's my comfort zone.
Yeah,
But that's
many of them, excuse me, many of them have already well, when they see me, they're having back pain, and many of them already have had physical therapy, but it's usually when they leave, I want that continuity for life.
absolutely.
And that's where I get that problem, and also, as a doctor, you know what it is like. You don't necessarily see them again. So to be able to follow up with them in a year and say, well, how's it going? You can't bill for that, you know. So anyway, thank you.
Yeah, absolutely. I see a comment here. It seems I may have offended someone, so let me just make sure I correct myself here. I would recommend starting with PTs to get them started, and then when stable, refer to an exercise specialist. I couldn't agree more. I co-own the Medicine Rehab Fitness Institute, where one of the co-owners is a physical therapist. We actually co-presented at the APTA's annual conference 2 years ago. It was actually a 7-hour pre-conference co-presentation. So yeah, I couldn't agree with that more. I was just giving an example where sometimes they would be bypassed, just to kind of make my point. But yeah, I couldn't agree more. And yes, while it is true that PTs can do total body strengthening, um, it's because insurance is limiting your number of visits to approximately the 8 to 12. With the exception of outlier situations that you typically can't. And so, yes, I couldn't agree more that you need good trainers to hand them off to safely. And yes, that's what Sheila Thomas and I, we talk, that's what we talk about through the MRF Institute over and over again. So yeah, I hope what I said wasn't offending, because I'm a huge fan of physical therapy, and it really is the ideal pathway. Medicine, rehab, but then instead of rehab to a home exercise program, which is typically the case about 90+% of the time in traditional orthopedic physical therapy, instead of that, make sure that the physical therapist has qualified fitness professionals within their network, and whenever possible, hand them off for that continuum or that continuity of care. So, but yeah, I was not trying to be offending there. I am a huge fan of the medicine rehab fitness pathway.
Jeff, if I could just take a minute, Dr. Morani, another idea would be if you have the time, space, capacity to consider doing some shared medical appointments for your patients, that since you have a whole group of patients who fit a certain description, that's a perfect opportunity for a shared medical appointment. So you just invite them all in. It's an office visit for all of them. And you can bring in an exercise specialist to the office visit to help provide the education. I've done it with stretching. So I've done it in the cardiology practice where I was, and we had about 20 patients and their family member that I let come for free. It was a great PR thing for the practice because a lot of those family members ended up coming to us saying, wow, this is a cool thing that they offer, and they're nice people. And you get the exercise specialist in there. So then you're introducing them to your patients, like they're seeing them face to face, and they're seeing a professional, well done, long, it's usually like an hour. So they're getting a long visit. It's a win-win-win. It's a win for the patient, win for you, and a win for the exercise professional as well.
Thank you. And if I may follow up with you, Sheila and Alyssa, when you have patients doing resistance exercises, let's say for osteoporosis or whatever, are we just sort of getting them exercising and we're increasing load to try to promote muscle hypertrophy, et cetera, or are you getting a little deeper and are you doing body composition testing, or is that just not, do you think that's too involved?
In my primary care practice, we do body composition testing. We have an InBody, and I definitely monitor patients who are working with Elise. I don't know if Elise knows that, but I just had a patient who recently fired her own personal trainer that she was having come to her home 3 days a week because her InBody looks worse after a year. And she's been paying that guy 3 days a week to come to her home and train her. And she said, if I've been working this hard and my muscle mass has declined and body fat has increased a little bit, something is wrong. So she's now ready to talk to Elise. I didn't push Elise in the beginning because she had this guy coming to her home 3 days a week.
Mm-hmm. And I'll just piggyback off that. It all just depends on the patient and where they get their medical service, you know, who their medical service provider is. So some folks come and they'll say, hey, Elise, I have a DEXA scan coming up. And so I'll say, okay, I'll mark it down on my calendar. Make sure after they go to their appointment, just fill me in on the results of what it is. If they do provide some type of body composition, then that's great. But I'm not so much involved in that because it depends in the beginning stage, because it all depends on their service provider and what perks that they may be able to receive. So if it is something, it can be involved in the conversation. But if they don't have that accessible to them, then it is something that's out the equation. But it does sound like that's something that you provide. So that's great. Those are things that we could continue to sprinkle into our conversations and keep in mind.
Thank you.
Prasanthi.
Yes, I have a question. Actually, I'm an endocrinologist and I am doing diabetes remission programs. I did include the exercise, even though it's not written in the curriculum anywhere, but I have included the exercise part in it, and we wanted to do like some cooking demos. So all of it is basically including all parts of lifestyle. So we have finished the program. During the program, we have done it as shared medical appointment, which means my exercise specialist will do like a half an hour exercise. I'm doing coaching, and then we may have a psychologist. But then after we finished, I was debating on doing it as shared medical appointment just for the exercise. But anyway, we started. But how do you code it? Is it like 213, 214, or how much time do I have to spend with them in order to code it as shared medical appointment?
Yeah, so I can take that one. The shared medical appointment cannot be based on time. So
Right.
You cannot use a time base for the shared medical appointment visit. So it's only based on the medical decision making and complexity of the visit. So often it's 99213.
Okay.
You know, you can get a pretty decent physical exam done just visually when you're in the room with the patient. And when I was in the cardiology office, I would also listen to heart and lungs and check a couple pulses and document a little bit of a physical exam for everybody. So
But they're virtual. you cannot do that, right?
Virtual, you can't listen to heart and lungs, but
Right, yeah. Yeah.
you can document no visible effort of breathing,
Right,
you
right.
know, that type of thing. So you can document a couple different body systems, but really it's their number of diagnoses and did you write a refill prescription or, you know, review their meds and do some other things for that qualify for medical decision making. But I would say you're very safe with a 99213 on pretty much every patient.
Okay.
If you have enough to qualify for a 214, go for it.
Okay. But I don't have to be, I mean, like I'm there, but I don't have to be spending a lot of time versus my exercise specialist doing.
Correct.
And
They can do the entire talking and teaching
Okay.
in that visit. Yes.
okay. And I have one more quick question. If my exercise specialist, I mean, like she's still like kinesiologist, but then we don't have her certificate or anything in our office or our facility doesn't have it. What are the, I mean, how do I justify her doing like one-on-one coaching? I mean, I need some help with the coding part of it. In case I don't have a certified physical therapist, which it may happen soon, but in general, if I'm just using a coach or a specialist or somebody, how do I justify other than shared medical appointments?
You're talking about trying to bill?
Bill for the physical therapy or yeah, one-on-one, like she does do the assessments and she does do like, I mean, she's a kinesiologist, like I said, she's just graduating, but she doesn't have the physical therapy license because she's came from a different country.
Yeah, that's I don't think you can because fitness, even medical fitness, is currently out of pocket.
Okay.
As I mentioned earlier on in not that I would expect you to remember everything I said, but the fitness industry is currently being professionalized. So it doesn't help you right now, but in about 2 years, you will be able to bill for the services of qualified exercise specialists. It's called a QHP movement, non-licensed qualified healthcare provider. So the movement is going on. If you want to stay in touch with me on it, because I'm very involved with it.
Uh-huh.
So but right now it is out of pocket expense.
I will say that I think there are potentially a few assessments that you might be able to bill for if that person is doing certain types of tests. Like I know with our peripheral artery disease clinic, there was a 6-minute walk test or something like that that we could bill for that assessment. And we didn't have to be a PT or certified or
Okay.
whatever. So you might look into some of the assessments. Like I believe assessing body composition, there may be a code for that. And maybe you get $8 or $10 or something, but at least you're getting something for that, right?
Right. Yeah.
And just real quick, as an FYI, I've been staff at Beth Israel Medical Center's Friedman Diabetes Institute as a fitness educator, UCLA Medical Center's Gonda Diabetes Institute as a fitness educator, Duke University Medical Center's Diet and Fitness Center, which while I was there was arguably the leading medical weight loss facility in the U.S. or one of the top 2 or 3. And I just earlier this year, I presented at the Obesity Medicine Association's annual conference in Denver, and I'm very involved with and very passionate about this world as well. So if there's any way that I can help you at all with anything, I'm happy to help.
Yeah, sure. Thank you. I'll contact you.
Absolutely.
Jeff,
So
there's a question in the chat of when will you have part 2 for this?
Tomorrow. I don't know, but it'll be. I don't. While the fire's burning, I want to keep it going. So I don't think it would make any sense to wait too long. But at the same time, we, the MRF Institute, are putting out, regular um, uh, webinars. I don't. It's tough for me to answer. I would say 2 or 3 weeks, no later than a month. I think if it's longer than a month, we're going to start losing interest. So if anyone wants to give me feedback on that, again, either through email, I think we really need to wrap this up now. So you can send me an email or put it in the chat box real quick, or to give me a sense of how soon I should do this. But it'll be sooner than later, and it won't be longer than a month. And
Well,
probably
because next month is the meeting, the American College of Lifestyle meeting.
oh yeah. Well, actually,
So
it's the end of this month.
This month.
Yeah, and
correct. So So I would love to see a part 2, maybe in the next few weeks.
Before then, is that what you're saying?
Yeah.
Okay,
Yeah, that would be
Alright.
good.
that sounds good. All right, thank you all so much
Thank
for
you. Good
really
night.
appreciate it.
Thank you.
Yeah, and we'll talk to you soon.
Bye-bye.
All right,
Night,
take care.
everyone.